So, warm welcome to you to this lecture on health systems and financing. In this lecture, we'll be covering from a global health perspective some elements of what constitutes a health system, as well as the way a health system is financed, and look at different ways of health financing in high income, low middle income, and low income countries. So, to begin with, what really is a health system? A health system comprises all organizations, institutions, and resources that are devoted to producing actions whose primary intent is really to improve health. A health system comprises many elements. These elements can be looked at in terms of one, service delivery, two, the health workforce, three, the health information system, four, medical products, vaccines, technologies, and the way they are licensed and marketed in a country, and then health financing, and lastly, leadership and governance. Now, this lecture will focus primarily on service delivery, the health workforce, and the way healthcare is financed. Health information systems is a whole topic in itself, as is medical products, vaccines, technologies, and their licensing and governance. So, we're going to focus now on service delivery, the workforce, and the way healthcare is financed in this lecture. Now, if we were to first look at service delivery, there are two ways in which it works. One is who provides for healthcare, and the other axis is who pays for healthcare. Now, healthcare provision can either be public, that means delivered by the public sector, or private. And under private, you could also have traditional and informal methods. So, traditional healers could be like naturopaths, etc. And informal healers are those you see in the low income countries and include those who are like faith healers or bone setters, etc. The other question is who pays for healthcare. And healthcare can be social health insurance, which is tax financed. That is, there's a tax base that pays for it, or it can be social health insurance, which is paid for by employee contributions into a sickness fund, or you could pay out of pocket, as occurs in some low income countries where people pay out of their savings for healthcare, or some people who in some countries choose to have private health insurance. There's a small element that I haven't really talked about or won't talk about in detail, and that is the concept of user fees, which existed in the 90s in some low middle income countries, where each user of a health facility had to pay a small fee out of pocket to use the healthcare system and was believed to contribute to the resource based and resource constrained settings to run healthcare systems. However, there's been evidence now that shows that that hasn't really worked. So I'm not really going to focus on user fees in this talk, but you can read it up if you're interested. Now, the first thing we're going to talk about is the health workforce, which is probably one of the most critical elements of a healthcare system to ensure that the population actually has decent health outcomes. Who constitutes the health force? We intuitively think of the health force as doctors and nurses, but the workforce is really all people who are engaged in actions whose primary intent is to enhance health. And this could include the skilled workforce like doctors, nurses, pharmacists, etc. But it also includes a lot of ancillary staff and paramedical staff, including accountants, managers, etc., who ensure that the health system functions smoothly. But if we were to really focus on the technical health staff, which is responsible for delivering health outcomes, I've presented here the density of doctors in a number of countries for you to see the gradient that there is between different low-income and high-income countries. Now in Zambia, we have 0.12 doctors per 1,000 population. Tanzania even lower. India 0.6 doctors per 1,000 population. Cuba 5.9, which is quite high. And then where we are in Sweden, 3.4 doctors per 1,000 population. So you can see this gradient as you go from low income to low middle income to high income countries. Cuba is a bit of an exception, but I've put it there for you to see the exception. It's quite similar when you look at nurses. Nurses per 1,000 population in the low income world. Zambia 1.74, India 0.8, Cuba 7, and Sweden where we are 10. Now, if we were to look at the global distribution of the health workforce, and you look at this map, you can see that there is a concentration of the health workforce in the global north, in the high income world. And if you look, there's a belt running through the global south, through much of Africa, India, and Oceania, where the density of the health workforce is relatively low. So, in this map, the darker the color, the higher the workforce density. Now, if you just hold this picture in your mind and then compare it with the slide that we'll see next, which actually looks at maternal mortality outcomes in the world, you can nearly see a clear overlap that areas which have a lower density of the health workforce seem to have much higher maternal mortality ratios. Again, the darker the color, the higher the maternal mortality ratio, the lighter the color, the lower the maternal mortality ratio. I've tried to put these two slides together. The slides are a bit small, but perhaps you'll be able to see the relationship here. So you can see that in the high income world, where there is a high density of health manpower, you can actually see maternal mortality outcomes are much better, and vice versa. Now, if we were to look at the WHO Health Report 2006 and look at the y-axis, on the y-axis you see the probability of survival, child survival, maternal survival, and infant survival, and on the x-axis you actually see the proportion of health workers in the population. And you can see that as we move to higher and higher densities of health workers, survival also tends to increase proportionately in nearly a linear way. So we've talked now about health services being public or private, and under private you could have informal or traditional. We've talked a little bit about the healthcare workforce and the importance of workforce for health outcomes and the way the distribution of health workforce in the world. And now we're going to move on to an important topic of health financing. How is healthcare actually paid for? So, healthcare financing is actually a flow of money into the health sector, which is then used for healthcare, which are the expenditures. Now, the financing of healthcare must actually be distinguished from the production of healthcare services because the financing of healthcare could be from the public or the private sector, and then the delivery of health services could again be from the public or the private sector. So, the public sector could finance healthcare to be delivered by the private sector. So that means there is a flow of resources from the public to the private sector, or the public sector could finance healthcare as well as be responsible for the delivery of health services. But you need to be able to think of these things as two separate elements. So, who pays for healthcare, how is it spent, and by whom are the important questions that we need to ask from a global health perspective. I'm coming back to this older slide that I had presented on who provides healthcare and who pays for healthcare. Now, sometimes the public sector is a provider of healthcare, delivers healthcare, and this healthcare can be paid for through social health insurance or a tax-based system. Sometimes the provider can be private sector providers, and these providers can sometimes be paid through the public sector either via tax-based systems or social health insurance, or they might be paid for by private health insurance plans that certain citizens have. Or often, as is seen in low-income countries, they tend to be paid for out of pocket, where individual citizens pay for healthcare from their savings or their current earnings. Traditional and informal providers are kinds of private sector providers. Some private insurance plans cater for healthcare to be provided by these kind of providers, but most often they tend to be paid for out of pocket. Now, if we were to look at different countries in the world, going from high to low, so on the left-hand bar actually shows you how health expenditure is broken up in high-income countries, and the right-hand most bar shows you how health is paid for in low-income countries. Now, the orange segments actually refer to risk pooling or health insurance paid for either through tax-based systems or through social security. And the blue parts refer to private health expenditure, and this could either be private health insurance or private plans or out-of-pocket expenses. Now you'll see in the high-income world, the orange bar constitutes about 60% of all health expenditure, which means that 60% of all expenditure made on health is actually paid for by some form of public insurance. And if you were to actually consider insurance as a whole, prepaid plans, private plans are also quite high. So about 80% of all health expenditure comes from some form of insurance. There's just a minuscule 20% that is paid for out of pocket or through other private means. And as we go down the income scale in countries, you can actually see how this proportion shifts. So that by the time we actually reach low income countries, you can see that the proportion that's coming from insurance, private insurance is negligible, but social security or government insurance based systems is very, very low. And about 80% of all health expenditure in low income countries is actually made out of pocket by the citizens. So this is just a figure for you to remember that in the high income world we do have a good degree of risk pooling, but that the same doesn't occur in the low income world. In the low income world, people often have to fend for themselves pretty much and pay out of pocket. Now, if we were to look here, these two graphs, this actually tells us about how much health can money buy. Now, if you look at the top graph, you tend to see on the x-axis here is the total GDP per capita in different countries in US dollars, and on the y-axis is the amount that is spent on health. And you can see that the richer people tend to get the more money they spend on health. And in the lower graph, what you see is the health expenditure on the x-axis and the life expectancy on the y-axis. So how much life expectancy can you buy based on how much you spend on health? And you can see that there is a sharp increase in life expectancy right at the beginning of the curve. So when you go from 0 US dollars to about 500 or 300 US dollars per capita, life expectancy tends to increase very sharply. Thereafter, it tends to taper off in the sense that the gains are not so efficient. You could spend a lot more money but not really gain that much more in terms of life years. But at the beginning, there definitely is a relationship between the total health expenditure and the life expectancy. So now to just recap a few questions. How do most people in the world's poorest countries pay for healthcare? And if you remember the graph, the orange and the blue graph, which I had shown you earlier on, so 80% of health expenditure in the low-income world actually is paid for out of pocket by citizens. How does out-of-pocket spending for healthcare compare in rich countries versus poor countries? So like I said, 80% in poor countries is out-of-pocket, whereas in the rich countries, it's less than 20%. So here's a little snippet of information just for you to put things in perspective. So in Germany, where they have a GDP per capita of 33,000 US dollars, only 11% of all medical expenses are borne by households, which means close to 90% is paid for by social health insurance or by government. And you can contrast this to the Republic of Congo, which is a low-income country, which has a per capita income of just 120 US dollars, where 90% of all money spent in the health system is actually paid directly by households to providers. Now, what is the problem with this form of payment for healthcare? Why are we worried about out-of-pocket payments? Out-of-pocket payments are perhaps the most regressive form of payment because many people are deterred from using health services when they need them because they can't afford it, or they're unable to continue a complete course of treatment to feel well again because they can't afford it. And because the money is drawn out of savings or out of money that they may have or earn currently, they do need to often cut back on basic needs such as food, clothing, or children's education just to meet health costs, which create a barrier to actually using healthcare services when you need them. So globally, every year, about 150 million people experience some kind of financial catastrophe, meaning that they're obliged to spend more than 40% of their available income on healthcare. And another 100 million people actually are driven below poverty line because of having to meet healthcare costs out of pocket. So out of pocket healthcare, which is a common mode of payment in low income countries, is actually quite regressive and tends to make people poorer. This brings us quite naturally to this concept of social health protection or risk pooling, whereby we create a system called a risk pool that allows a large group of people to be able to share the risk that they may become ill and may then need expensive care. It ensures the risk of having to pay for healthcare is borne by members of a pool and not by each contributor individually. So, if you have this pool at any point in time, there is a proportion of members who are healthy and a small part that are sick and need to draw more heavily on health resources. So, the healthy members at any point in time are actually subsidizing the sicker ones that need to draw on available healthcare resources. This is the concept behind social health insurance or risk pooling or any form of health insurance, really. Now, if we were to look at national health systems and the way social health protection is paid for, the most common mechanism is tax funded healthcare financing. And this is the system you see in countries like the UK and in Canada, whereby the government collects money from its tax revenues, and then part of this is apportioned to pay for healthcare, and it's routed through a Ministry of Health, which then distributes this money to healthcare providers either in the public or the private sector. And it's used to pay to run hospitals, to pay salaries, to pay managers, laundry services, etc., that are required further downstream. Another method of risk pooling is social health insurance, which is used in the continent in some countries, in Belgium, in Germany, whereby there is a contribution from the employer and the employee towards something called a sickness fund. And the sickness fund then pays healthcare providers, either in the public or private sectors, to be able to deliver healthcare to the members who contribute to the sickness fund. Now, social health insurance has a potential to be quickly upscaled into universal health coverage because governments then pitch in to pay for those members who are disabled or unable to pay, unable to contribute themselves, thereby increasing the pool and increasing the access to healthcare for all citizens. And you can have systems that are mixed, where there's also an element of private healthcare insurance plans that come into the picture, like you do have in the US. These are broadly the main methods. There could be other methods for social healthcare protection, but from this lecture, if you understand these two main methods and read up on the rest, it's fine. Now, if we were to look at the way health is financed in OECD, that's the high income countries, and in low middle income countries. Now, in all OECD countries, with the exception of the US, have predominantly a taxed base or some form of social health insurance. The US, in contrast, has private health insurance plans and large out of pocket expenses if you don't have private health insurance. There is some degree of social health insurance via the Medicare, but it's not really the mainstream form of paying for health. In low middle income countries and in low income countries, there is quite a spectrum of the way healthcare is paid for. Large parts actually are privately paid for out of pocket by households. A very, very small proportion of people have private health insurance, those who can afford it, and there is some tax funded health system. But there always is a problem in low income countries because the tax base is often very small, and then to apportion that further into healthcare doesn't make for a very functional health system always. So, tax funded health systems are problematic with different levels of dysfunctionality in low income countries. And then you also have social health insurance systems that are paid for by employers and employees, but formal employment in low income countries is again quite a small proportion of the population. So, there's just a restricted section of the population that can benefit from social health insurance. Right, so that just brings us to the end of this lecture, which talks about so far the way healthcare services are delivered. It talks about the way the health workforce and the way the healthcare workforce is spread across the globe, the relationship between the health workforce to health outcomes. And it introduces you to the way healthcare systems are financed in the low income world and in the high income world. And to end this lecture, I just thought I'd put up a few thought provoking questions for you to think about. What is the total global expenditure on health? It is $4.1 trillion. And on average, what do we pay per person for the health per person per year globally? And that's about 640 US dollars. And a country with the highest total spending per person per year on health, this is the US, which spends about 6,000 US dollars per year per person. And this doesn't mean that the government is spending that money, it's the money that's spent by the country per person on health. And varying proportions of this amount actually come from the person or private health insurance. The country with the lowest total spending per person per year on health is Burundi, which spends $3 per capita. And the country with the highest government spending per person per year on health is Norway, which spends about 2,700 US dollars per citizen on healthcare every year. The average amount spent per person per year in OECD or high income countries is about 2,700. This is as opposed to the global average of 600 and the US amount of 6,000. Now, the proportion of people living in OECD countries is 18%, 18%, and yet the percentage of the world's total financial resources that are devoted to health currently spent in these high-income countries is about 80% or 80%. So I hope that gives you a good introduction to health systems and financing and spurs you on to read further. Thank you for listening.